Good morning, everyone, or afternoon, depending on when you're watching the show. Welcome to the Spot for Health, and my name is Shirley Gutkowski. I'm your host today, and I would like to introduce you to our special guest today is Dr. Brian Fick. Dr. Fick has been in the Madison area for a number of years, and now he is one of the premier doctors at First Choice. He has been caring for patients over there at the Park Street location. There's a lot of First Choice offices around. He practices general dentistry and also has advanced training in treating TMJ disorders and airway disorders. He's increasingly proficient in Spanish. Yay! Can't have enough Spanish-speaking dentists around here. Dr. Fick enjoys speaking Spanish with his patients at the Park Street office and providing needed dental care to residents in Central America on numerous medical mission trips. Dr. Fick also enjoys his free time with his wife and 2 daughters, cooking, downhill skiing, and honing his collection of rock and jazz. Welcome, Dr. Fick.
Thank you, Shirley.
Thanks so much for joining us today. We spent a little time with orthodontist dentist a couple weeks ago talking about airway in children and developing the airway, and I thought it would be interesting and important to also talk about adult airway issues.
Absolutely. I think it's maybe a little bit of a non-conventional thought pattern for a patient to get some of these difficulties addressed with a dentist, and certainly the medical community provides fantastic services for many of these things too. But I do think that dentistry increasingly has a pretty unique role to play because of maybe the gateway or the window that these patients come to us through. For example, as you talked to Dr. Passion last week, he deals with children, and children's airways that are restricted cause all kinds of problems, some of those behavioral and some of those sleep-related. But in terms of the adult community, which I tend to treat a little more of, I see patients that come to me with maybe some airway difficulties through the window of temporomandibular joint disorders, or TMD. So for some background with me, I've been doing dentistry 24 years, and the first 20 years I was doing general dentistry, and now increasingly I've been doing TMD treatment. Advanced studies in neuromuscular dentistry and different ways to position the jaw and correct the bite to stabilize the TMJ have led me to really kind of something that was, I think, poorly understood for a long time, at least in dentistry, which was what is nocturnal bruxism? Why do people clench and grind their teeth? To what extent did this clenching and grinding cause other problems, and really what the etiology of that was. And it's kind of exciting for me because I feel like at this point in the game we're finally putting a little bit of a flashlight on why people do brux and grind. I'm very open to the idea that people brux and grind for a lot of different reasons, but certainly it is becoming, I think, more clear that one reason that people do brux and grind is that if they have a little airway collapse during sleep or even during the day, sometimes the brain uses clenching and bruxism to increase neck muscle tonus. When the muscles of the neck become tighter, it opens the airway a bit. So it does appear now that bruxism does provide kind of a corrective function for the airway.
Or a warning function.
Or a warning function.
For the sleeper, right? Because sometimes I've ground my teeth enough to wake myself up on occasion. And I think there are other people that maybe grind also just in an effort to wake themselves up a little bit, or at least even get these muscles going like you were just describing.
Yeah, I think it's probably still open to debate whether or not the bruxism's role is to wake you up or just to maintain the airway, and maybe the slight collapse of the airway is really what woke you up, but it might be splitting hairs a bit.
Yeah.
So the thing is that I think that if we look at bruxism as a way for the body to try to stabilize the airway, then it's providing a kind of safety valve for a kind of collapsing system, but of course this safety valve has its own set of sequelae that cause problems. Bruxism is known to cause pressure on the joint. I think there's some increased body of evidence that could say that the head of the mandible can get displaced off the disc in your TMJ with excessive forces, bruxism, and grinding. So this clenching that the brain might be using to rectify one problem leads to another problem.
That doesn't happen in any other body system ever at all, right?
It seems that as we age, we learn about those things a little more.
It's crazy. So what I've been kind of putting my head around a little bit is that things that happen when we were younger, like let's say we did have a narrow sinuses and we had to breathe with our mouth open, and we had problems with our tongue, or the tongue fell back into the throat, or whatever all of those kind of things were, we were able to compensate for. Just like kids with a tongue tie can learn how to speak properly, even though the tied tongue may be causing some airway issues or some structural issues as the face is growing. But by the time you're 40, that's pretty much toast. Your body was expected to work in a certain way, and if it has to compensate this whole time, finally by the time you're 40, it seems that you're on blood pressure medications, you're on restless leg syndrome medications, you have TMJ problems, and things just get loud enough that you have to take more of an active role in treating those issues, and usually it's a pill. But with dentistry, we have other better options.
Yeah, I mean, part of the world that's exciting to me within Airway, and there's a good bit of controversy about this, and I don't think we have all the answers by any stretch. But when you look at major airway collapse like apnea, there's also a disease profile that's increasingly gaining some momentum called UARS, upper airway resistance syndrome, and that tends to be, if not a little more focused towards the female patient, at least certainly more distributed than apnea, which maybe strikes a few more men. And this kind of minor airway collapse is something that over time, as you point out, certainly seems to get a little bit worse in the 40s and beyond, particularly with women. And there's been some suggestion that actually, as you go through menopause and progesterone becomes a little bit more of an issue, that protective quality of progesterone that it has on the airway diminishes and creates maybe a little more of a risk for airway collapse, where, as you point out, you had some of the things upstream that were waiting to take hold, but you were able to hold them off because of maybe some quality of the airway that was, a little bit more resilient. And then hormonally you're not able to, so you start to slip into more of a...
So we have a little graphic about a comparison between the what was it again? UARS and sleep apnea. And it's always very striking to me that the UARS list includes some really different kind of categories, like fibromyalgia, and it's the little graph. There we go. That's the one. Fibromyalgia and chronic pain problems, and this may be a result of having a much narrower airway. So it would be the difference between breathing through like a soda straw or a Culver's cement mixer straw and a swizzle stick straw. So that airway is affecting numerous areas in your life, in a person's life.
Yeah. This whole topic is massively complicated.
Yeah.
There is a lot of controversy about it, and I have no formal training as a sleep physician might. My training is through a lot of conferences and a lot of discussion among a lot of people that are really exploring this. But I think that whenever we're talking about these issues, it's important that you know, it's really multidisciplinary. Sleep physicians involved,
Exactly.
physicians involved, physical therapists involved, occupational therapists involved, myofunctional therapists involved, everybody involved in one. So I certainly don't have all the answers, but my understanding about the UARS is much like what you've said. Patients that come to me for TMJ problems tend to be clenching, and it seems like the clenching is related to a more minor collapse that's associated with this UARS. Couple things to keep in mind about UARS if the viewers would like to do more research. One is that there's a really nice book written for the lay public that's written by a physician, an ear, nose, and throat physician. Stephen Park is his name. You can find it on many online booksellers. It's called Sleep Interrupted. And the reason, so that's one thing, Stephen Park, Sleep Interrupted. And there's another researcher on the East Coast, Avram Gold, who's done a lot of research on, he's a sleep physician, done a lot of research on the connection between UARS, upper airway resistance syndrome, inspiratory flow limitation, and the ways in which this can be linked to, at least he proposes, linked to things like fibromyalgia, irritable bowel syndrome, and other chronic problems that seem to be related to an overactive sympathetic nervous system. When we sleep, we like to live in parasympathetic nervous system, which is a more restful and a more metabolically helpful kind of situation. But if you get a micro airway collapse, the brain needs to wake up to manage that. The moment the brain wakes up, even if you don't wake up, if your brain wakes up, your pulse increases, your functionality moves towards this more sympathetic, more fight or flight response. And the proposal, at least from Dr. Gold, is that this sympathetic activation over a period of time, years and years, leads to many of these chronic problems, or can at least be a piece of the puzzle. So, you know, we talk to patients about different things that, some of which are relatively simple, that can have been proposed to help alleviate this micro collapse, get a better, more deeper night's sleep, spend more time in uninterrupted sleep, spend more time in level 3, 4 in REM sleep, which is where you really heal yourself, and then and fix some of these things.
So how does dentistry fit in then? Do you collaborate with a sleep physician and they recommend patients go to see you, or do you work it the other way? What is dentistry's role in all of this?
Like a lot of things that are kind of on the cutting edge, and I feel like the landscape is definitely one in which people handle it different ways. The thing that everyone needs to, I think, realize that's super important is that sleep physicians, pulmonologists, and the medical community need to be involved and in the very start of the process with any kind of diagnosis, because dentistry is not in a position, nor should it be, to make any kind of diagnosis. That would be problematic. But the ways in which the patients get to that medical diagnosis, I think, are changing a little bit. Some dentists around the country use online services that provide a home sleep test. So maybe the patient comes to the dentist, they fill out an Epworth sleepiness scale and some screening devices. They complain of daytime fatigue, restless leg syndrome, and they're not sleeping at all well, and maybe they snore. So they've got several risk factors, and recently they've been put on hypertensive meds, which correlate highly with apnea. So they've got these kind of set of characteristics to their problem which fit in that, and then maybe the dentist might recommend that they use a home sleep test, and they can get those from various places through their physicians. They can get them online. Some online providers send the sleep test to the patient. They use it for 3 nights. Then they send it back in. Usually in those cases, the home sleep test comes back in to the online service that sent it to them, and the data is read by a board-certified sleep physician. Once that diagnosis is made by a board-certified sleep physician, dentists can be involved in the treatment of some of those patients. There are realms of apnea that are moderate to severe that don't maybe always respond as well to a dental device, and there are wonderful CPAP devices that work great too. Some of these CPAP devices patients love, some don't like, so I think dentistry's role is really as one in which we can offer something that patients might use in some cases depending on their depth of problem, and so it is a. And then certainly another route to handling this is patients that see their physician, and maybe this physician might recommend that they have a sleep test because maybe the hypertensive meds are new, or maybe they're coming onto a second hypertensive med because the first one didn't work right. And then and the physicians may be saying, hey, let's get a sleep study. And then the patient is spending more time in the medical community and then maybe ends up in dentistry for one of these oral devices to help with their apnea. So there are a lot of different things going on.
A lot of different ways. So do you screen for this when you're seeing patients in your regular practice? So let's say the patient comes in, they have their teeth cleaned, and you come in and do an exam. Is there something that maybe might trigger you as a dentist to say, this might be an issue?
There are a lot of people proposing the fact that this airway difficulty as you breathe is related to a lot of different factors, and some of which you kind of hit on earlier, and I think Dr. Passion probably hit on last week, which is to say that we feel like, or at least we feel like the early evidence is suggesting that the shape of the intraoral cavity, the degree to which your row of teeth is narrow or broad, the height of your bite, the position of your tongue, all affect airway. So definitely there can be other factors, but if these are improved, sometimes the apnea improves, or the UARS improves. So dentistry absolutely has a role to play, plus patients see dentists generally more often than their physicians. They're coming to see us every 6 months, generally speaking. So I do think we have a role in screening these type of things. At First Choice, we have 9 locations, soon to be 11. We have a lot of different areas that people can very easily access our treatment facilities. We have, currently we're working on a system where patients can get some of these services done by us. I work at the Park Street location, and currently we manage most of these services there. But yeah, we are screening more every day. Right now we're piloting it mainly at Park Street with kind of a stop bang, which is kind of a funny name. It's just a brief 5-question survey that kind of allows us to maybe ask some other questions if any one of those 5 come up as yeses, or maybe say 2 out of 5 come up as yeses, then we go a little deeper with maybe another screening device called an Epworth. So there are a couple different modalities of screening. We have not implemented that fully throughout First Choice, but we are doing it at Park Street, and I do see a future day when just, airway and how people breathe is incredibly important. And I really feel like, I know you're on the same page with this, but
yeah.
I feel like with respect to all of medicine, this is a exploding area. We really have known a lot, not as much about sleep and about how we breathe. And it's very important. And if dentistry can provide a little role in terms on the back end, maybe with services like oral devices, and then on the front end, maybe with just a quick little screening thing that might really save a patient's life, or at least, or significantly improve the quality of the life, then I think that would be a great thing for dentistry to be able to do.
Yeah. So let's back up just a couple of steps. One, what is this Park Street address?
621 South Park Street. It's pretty close to St. Mary's, across the street, and just back towards campus a little bit. Okay,
and then they can find it at firstchoice.com. I think is the website.
Firstchoicedental.com.
Firstchoicedental.com.
Yeah.
Okay, good. So that's number one, and then you said kind of a funny word, stop bang, and I want to point out that that's an acronym for the name of the test.
Right.
So, and it's a paper test. It's not like you have to give a blood sample or
a
saliva sample. You don't have to get on a scale.
No.
You just have to fill out a little questionnaire.
Absolutely. 5 questions, simple questionnaire, and I got a funny name, but yeah, 5 questions, and kind of gives us, 30 seconds to figure out if you're having any risk things going on with that might be a piece of your airway puzzle.
Excellent. Okay, and while we're talking about First Choice for just a second, let's finish up by saying you've got a new office in Sun Prairie. This is the second office in one city except for Madison. I think that's
correct.
Correct.
For First
true.
Choice, yeah.
Yeah.
We have, we have offices in several locations, and we have our first Choice office in Sun Prairie was out by the Target.
Yep.
And
it's I got the address right here. It's 140 North City Station Drive. It's right next to the fire.
Right.
building.
And that's been, Sun Prairie's been very, very good to First Choice. We've had a fantastic presence here. We really feel humble and honored to be part of the community, and it's really been fantastic. And we were excited to put a second location here and help, serve more patients and help make the experience just as good as we can make it. And the new location is more on the north side, so we're calling it Sun Prairie North.
And that's on Wilburn, right across from the Cornerstone building.
Yes.
There used to be a big sign in front of that. We used to laugh about it all the time. Bank. So you took the bank sign down. That was it.
Maybe
just
we should
bank.
just say, should we just say teeth?
Teeth.
Teeth.
That just cracked me up for years and years. Bank. Okay, so that's on 119 Wilburn, and that's going to be opening in April.
Yeah, right around the corner. So we've got a second new location lagging slightly behind that, looking at late summer, early fall for our Stoughton location, which we're very excited about. But certainly Sun Prairie North, we expect it to be great and an awesome opportunity for patients in Sun Prairie to get our services, but also maybe to be a little more convenient towards the sort of more northeastern side of Sun Prairie, which is, Sun Prairie is, I think it's obviously it's a great community because it's growing and people really want to live here. So us being a small piece of that puzzle is fantastic.
Yeah, it's really exciting to have another First Choice office here in our city. Okay, so now let's go back to, so patients are coming to the dental office and they're expecting to get their teeth cleaned, they're expecting a filling. How this conversation for the airway has been, well, I don't want to say it's tricky, it's new to patients that these kind of conversations are potentially going to be happening. Right now they may be happening a lot more at your Park Street office, but eventually, maybe within the next year or so, they're going to have these conversations system-wide with First Choice and hopefully with other dental practices as well. So what should patients expect with that kind of thing so that they're not so surprised?
Well, I think that, logistically and how we roll that out throughout the company, I think is definitely an open discussion for us. We do want to be sensitive towards the needs that patients have for more traditional dental services, and our hygienists do a fantastic job, but they have a lot of things to get done too during their time. So we do, we are, I guess I would say, somewhat beta testing some of these systems and what works best at Park Street. In terms of the way we're screening, and then certainly this kind of landmark device protocols, 7-visit protocol in which patients can get an oral device from us to help with their apnea or sleep disordered breathing. That platform is almost in place, and certainly I would think by mid-April we should be able to treat patients very effectively with a home sleep test and getting a diagnosis from a board-certified sleep physician, and then moving on with that. That's getting very close to be in place. But the screening part we're still working on at Park Street. It's not been not too cumbersome, because again, you can always ask more questions, or the patients can always be referred from, let's say, a Sun Prairie to the Park Street to have, I should mention that, to have a free 45-minute consultation with myself about anything that they might be worried about with respect to the TMJ or airway or some of these symptoms we've talked about today. So even if the patient that's coming to Sun Prairie, even if there's not time in that hygienist schedule to do much more than say, oh, I see you're on a second hypertensive med, how's your sleep? oh, I sleep crummy. Why don't you go see Dr. Fick? I mean, that doesn't take a lot of time and really is an informal kind of way. I do think ultimately we would like to have some kind of little minor 4 or 5 question stop bang in place everywhere, but that's kind of an open discussion. We're moving and evolving with all that. So,
but I think this is not even just a first choice movement. I think it's a movement. This airway discussion is going through dentistry in general. I was speaking at the American Academy of Oral Systemic Health meeting at the Chicago Midwinter meeting a couple weeks ago, and that was the big hot topic, was this airway. We used to call it sleep issues or sleep dentistry, and the shift is going to be calling it more of an airway issue, which is what we've been talking about here. And I think patients in general are not really expecting that kind of a conversation. They're expecting the hygienist to go, oh, you're on a new medication. How did you spell that? And then that's it. But the conversations are changing in the dental practices, I think, nationwide.
Absolutely. And 2 things come to mind on that. One was grinding and bruxism we talked about, which we didn't really have a good handle on what was going on there. But another one that you will be near and dear to your heart as a hygienist too is that is oral breathing. You know, we for a long time patients would come in with inflamed gums, maybe more plaque at the gum line, more recalcitrant or not easily treatable gum disease, and these things were maybe related to a mouth breather. And we kind of said, well, it's not ideal to mouth breathe, maybe get a few more cleanings. Now we understand things, or at least the science seems to be suggesting that someone who's chronically mouth breathing has, you know, more of an increased risk for this UARS, this micro collapse that's harder to diagnose than apnea. So these airway problems are completely linked to things that we see in the mouth, and anatomy in the mouth affect this. I mean, a big piece of sleep disordered breathing is tongue position, and tongue position is based on your skull and training that you've had as a kid and whether or not your swallow reflex developed right. And if you nursed properly, I mean, it's just, it is absolutely amazing. And I think we're seeing it, you know, if you want to talk about it beyond dentistry, beyond airway, this notion we've had where dentistry and medicine was separate, it's been kind of, you know, let's just say we're evolving. We understand that these systems are all integrated, and the days are pretty much over where we can talk about dentistry and medicine as separate entities, I think.
Right, the silos are coming down.
They are.
And it's high time. I think it was important for all of us to be a little bit separate to really understand our little silo of what's happening. But, you know, come on, it's time to cross-reference a little bit. I like what you said about the mouth breathing too, because as a hygienist since 1986, you know, well, you should breathe with your mouth closed. But that was it. We had no tools to help them to get their mouth closed.
Yeah.
Nothing. And we would just, every 6 months, well, you're still breathing with your mouth open. Oh, well, you should stop that. You know, and that was it.
Yeah.
We have so many ways of getting people to get with their mouth closed during the day, at night. That may be one simple little thing that could make things a lot different, starting from childhood all the way to adulthood. I'm working with a couple of adults right now, and we're getting their mouth to be closed.
I think, absolutely. I think one massive paradigm shift for me a couple years ago when I was at a lecture in Chicago was just this notion where you made a great point where we're moving towards a discussion of this whole topic being airway instead of sleep dentistry. And the thing that's interesting about all this is that that's not just a name change. What you have to understand is that it's airway, because we're not just talking about while the patient sleeps. We're talking about 24/7 how you breathe. If you breathe consistently through your mouth in your life, day at the computer, whatever, these are, there is an opening realm of research that points to the fact that this can lead to problems. Heightened anxiety, lift of the sympathetic nervous system. None of this is conclusive and the evidence is still opening up, but airway, facial geometry, structural health, patency of the airway, all this stuff is interrelated, and it's not just while you sleep. We're a little more at risk when we sleep for a bunch of other factors, but overall, as you walk around, it's an airway thing 24/7.
Dr. Fick, thank you so much for joining us today on The Spot for Health, where Sun Prairie goes to learn about health and where to go for health. This is Shirley Gutkowski signing off. I hope you have a good rest of the day and share these episodes from the internet.